No. Okay. I will go to direct to our order sheet of DKA. I know that we will try to change this sheet, but it will take time to be officially changed. So
Yes, of course.
we'll try to revise this one point by point so it will be clear. Okay? So this is the sheet for admission of any diabetic patient, whatever he is in DKA or new onset diabetes, not in DKA, or a patient for dose adjustment. This is the 3 types of patients that we are admitting. So like the patient will be admitted to Unit 5, the diagnosis will be type 1 diabetes. I will write if a patient in DKA or admitted to rule out DKA, or the patient new onset diabetes to rule out DKA, or for dose adjustment. The diet, most of the time I'm writing the carbohydrate diet, how many calories for the patient. This is for the dietitian, but you know already that all the DKA patients now should be MPO until we stop the IV insulin. Okay? And here I will check, or me or Dr. Nasim, the one who are making orders, Dr. in ER, will check the labs that we need already. The CBC, random blood sugar, HbA1c, the electrolytes, and VBG. This is the most important. Mostly for the DKA patients, we are writing the lights and the VBG every 4 hours. Most of the time, the patient, the first time will be in Unit 5 or in ER, but we should repeat every 4 hours for lights and VBG if the patient is DKA. Creatinine, urine analysis, CBS, this is the capillary blood sugar. This will be every 1 hour, hourly in the DKA patients, and every 2 hours if the patient is not in DKA. And here's the TSH, and this is labs we are not ordering usually, it's only on special cases. And urine ketone per vial. Please, we need to check the urine ketone for every vial to the patient, so we have to tell the patient, you have to give us every sample you give. And we keep in the back room, and we have to check, because if he's in DKA, it will be +4, +3, +2, and this is a sign of improvement. So we have to check and write in his medication sheet, okay? And the insulin level is sometimes if we need. And here, the IV, every patient we should insert an IV cannula, even if he is not in DKA, because sometimes he has hypoglycemia unless if we have a glucagon at the urine. If we have glucagon kit, we cannot, we may not insert an IV cannula if the patient is not in DKA and we don't need it. But please try if you insert to be in the left hand, because most of the time I'm seeing the nurses that inserting it in the right hand, and it will be very difficult for the patient to eat and to move and everything. But if we didn't find the good veins in the left hand, it's okay, no other option, okay? And here, mostly we are starting a bolus for the patient, 10 ml per kg, this will be written by the doctor. He may receive it in ER if the patient came from ER. If he came from the outpatient, he will receive in the unit. This will be over 1 hour. As Dr. Nasim said, we don't want to be rapid in giving the IV fluids. Here's the IV maintenance and replacement. This is written by us, calculating the rate of the IV fluid, and here will be the final rate of the IV fluid. How many ml per hour? Whatever the fluid type, D5NS, NSS, whatever the fluid type. So usually if you have a DKA patient, if the patient finishes the bolus, you will shift to the next rate, this one, 155 ml, 150 ml, whatever, after finishing the bolus, according to the blood sugar, okay? And here's the type of the fluid. Now we are putting it on the system in details, according to the blood sugar. I will mention it later. Here's the insulin. Don't start the insulin without potassium level. You know all that the insulin is causing hypokalemia. So we never starting the IV insulin without potassium level. But recently we noticed that we are late in getting the electrolyte results. We may wait until more than 2 hours in getting the potassium level. So this is dangerous for the patient. Let's say the patient came at 6 p.m. to ER and we admitted him and we ordered VBG and the electrolyte, and the patient went to Unit 5 at 8 p.m. and we don't have the electrolytes yet. So we have to wait potassium level, and then we have to order the KCL to the pharmacy, and it will take 30 minutes. So we are delayed 2 or 3 hours to start with the IV insulin, and this is very dangerous. So nowadays, we are starting like randomly 15 or 10 milliequivalent KCL until we have the electrolytes, and then we can adjust according to the potassium level. Okay? The rate here take the IV insulin, it will be 0.1 unit per kg per hour, and here will be the total rate for the patient according to his weight. Like the patient weight is 50, so 0.1 kg, so it will be 5 units. Okay? Here, the sub-Q insulin. In the DKA, you will not find the sub-Q insulin because there's some misleading for some of the nurses. So I'm not writing the sub-Q insulin. If the patient is DKA, we will delay it until the patient is off of DKA. This is one patient admitted now, Sultan. He is 5 years. I just take a picture of this one. This is my order sheet. Like here, unit 5, rule out DKA. This is the diabetic diet. Here's the Glasgow coma scale. Like Dr. Nasim, when she said if the patient is comatose or not doing well, we are ordering to check this every 1 hour until the patient is fully conscious. And here, this is the order, the lights every 4 hours, VBG every 4 hours, CBS every 1 hour, because I'm expecting this patient to be in DKA. But what if the patient, you did the VBG and the VBG came normal, we will not repeat the lights and VBG every 4 hours. Khalas, no more repeated, okay? And here, this is the cannula and this is the bolus. His weight was almost 18, so 180 10 ml per kg per hour, and this is the type of the rate of the IV fluid. And here, the insulin, and I started already with 15 milli equivalent KCL, and this is 0.1 and 1.8, so 0.1 international unit per kg per hour. Okay? Sub-Q, I cross X, so that means that you will not receive any sub-Q now. Okay? And here's the rest of the sheet. This is the correction, CBS minus the target over sensitivity, like Latifa said. This is according to the doctor. We have a different protocol for every patient. Some of the patient minus 100 over 100, minus 150 over 100, minus 100 over 50, whatever. According to the doctor, keep glucagon. If we should have insulin for every patient, vital signs per routine, dietitian consultation, diabetic educator. Please, we have to inform for every patient. The dietitian should know about the patient within 2 hours of admission. Please. So just inform her so she can make the card, so she can know the patient is here, and also the diabetic educator. Okay? I will check some points. As we say, keep the patient MBO till the patient is off of DKA. Once the patient is not yet on IV insulin, don't put dextrose with the IV fluid, only NSS. Let's say that the patient will give the bolus and we finish, then the only fluid you will give is only NSS. Because some of them, I think they asked me one time, can we put D10 or D5? No, only NSS until we don't have insulin. In diabetic patient, don't build dextrose because you are giving him sugar. So you are raising his blood sugar until you have an IV insulin. So we will change the IV fluids according to the blood sugar. Like the type of the fluid according to the blood sugar. If it's more than 300, it will be NSS and the rate, the same rate. If the blood sugar from 150 to 300, D5 have NSS, we will shift. We will ordering it from the pharmacy, and you will have the 3 types of the fluid with you at the unit. Once you check the blood sugar and you found it 160, so you will shift to D5 have NSS, the same rate of IV fluids. Okay? And if it's less than 150, the type of IV fluid will be that D10 have NSS. Please, if you have a question, please stop me. Huh?
But doctor, if there is no insulin, we don't start the insulin, but the CBS is raised to 150 to 300, we can put D5
No, ever. Once we don't have an IV insulin, don't give the patient dextrose. You are raising his blood sugar by yourself. Yes, even if it's 150, even if it's 100, keep NSS. Once we have insulin, the other side should be dextrose, okay? What if the patient have hypoglycemia while he is on IV insulin? The patient is DKA and we started the IV insulin drip and the blood sugar is going down 100, 90, 80, 70, 60. What you will do, if the blood sugar is less than 70, please stop the IV insulin drip. This is the first thing you should do without any order of the doctor. This is clear. If the patient have hypoglycemia, we should stop the insulin. And then check after 10 minutes. You will stop only the insulin, but you will keep his dextrose. So it can give him, it can rise the blood sugar. Clear? The patient his blood sugar, sure, it was below 150. So he is on D10. So we'll stop the IV flow insulin and we will keep the D10. The D10 after 10 minutes, the blood sugar you'll find it's up 80 or 90 or 100. If okay, we can resume the IV insulin. If the patient still have hypoglycemia, hypoglycemia, at that time we may, by order of the doctor, we may decrease the insulin rate. Like if he is 4 units, we can decrease to 3.5, whatever. This is according to the doctor. But the first thing you have to do, you have to stop the IV insulin. You don't have to give him apple juice. He is already on D10. Okay? This is if he is on IV fluids.
Would you like us to call you, Doctora, if there is a bout of hypoglycemia?
Yes,
or
please.
we
First,
can
you will
manage?
stop from yourself, and then you should inform the doctor. Whatever, if there is doctor in the unit now, 24 hours we have doctor in the unit. If anything, he can call me or he can order to you.
So, you know,
Okay?
doctor, we are checking every hour CVS. If the CVS is less than 70, we need to stop the insulin drip, and we can reach up after
10
15 minutes
minutes.
or 10 minutes.
We should to make sure that the blood sugar is going up. And we should inform the doctor. But the first thing the nurse should do before informing the doctor, maybe the doctor is not near, he is in the clinic, he is wherever, she should stop the insulin and then she can tell the doctor.
Alright. Yeah, for example, the CBS is about 300, so the patient is on normal saline. And then there is sudden drop hypoglycemia, and the IV is normal saline.
He is on IV insulin?
Yeah.
Yeah, we should shift.
No, I mean IV fluid.
You know, usually
So
he will
it's
not
on
go,
normal saline.
he will not go down from 300 like to 70. It will go 300, then it will 200, 100. And if it's 70, the most of the time, the 2 hours before, it will be 90, 100 to this range. So you will be already on D10. Okay? So, خلاص the patient now is off of DKA when we consider, as Dr. Naseem said, if the BPG more than 7.3 and by far mostly more than 18, we can consider that the patient is almost off of DKA. Even if the ketone is negative or +1 or trace, it's okay. At that time, this is the time we have to shift to sub-Q insulin. How we will shift? We will start the basal insulin. You will inform the doctor, for me or the doctor is here, that that is already the BPG result. So we will shift, he will post the sub-Q insulin, whatever, the basal, the Tresiba, the Toujeo, Lantus, whatever the patient is on. And we have to start 30 minutes before stopping the IV insulin and the IV fluids. Okay, because this will take time. Because if you stop the IV insulin, the patient doesn't have insulin in his blood at all. So the blood sugar will go up. So we have to start 30 minutes before, and then we can stop the IV insulin and the IV fluids. Clear?
Yes.
Don't stop until you have the sub-Q insulin with you. And then the patient can eat. As we say that the patient is already MPO, then he can eat bolus insulin according to the order. If the patient is on Novorapid, on Pedia, on Actarapid, whatever the order, according to carb counting, he will be so hungry, so please prepare the food, give the insulin to the patient, measure before the food, and then give the food, and then we will check every 2 hours. We are not more in DKA. And please inform us with the postprandial because every meal is important to us. We are adjusting the dose for every meal because if the blood sugar is high, we may increase the dose, so we will use the time. The next meal it will be higher, or if he has hypoglycemia, we will change the dose. So please, if you found, even if the reading is normal, you should inform us. Call me, no problem, anytime. The post breakfast is 300. You will change the dose. I will tell you, please increase the dose. Maybe we have some problem with the calculation, so we can check what is the problem. Okay? What is hypoglycemia while the patient is off of DKA? Latifa told you what you will do if the patient blood sugar will less than 70, the 15 rule. Okay? What is hyperglycemia? If the blood sugar is high, you will make correction, but you will make correction with meals. Okay? Let's say that you measure post breakfast 2 hours and you found the blood sugar is 300. What you will do? 2 hours post breakfast. You will not do anything. Okay, please wait until the lunch time and you will measure again and you will make correction with food. Because the patient, day, night, he will eat. But if overnight, with no rapid, you can make correction. I will go to this next slide. Okay?
Please, all nurse, when you check the CVS, check the parents. If the patient eat before the CVS time or not. Because again, it's give wrong dose or wrong insulin. Please, again, anytime you go to the patient to check, ask the patient he eat or not. When last time he eat?
Yeah, because sometimes they have juice in the room. Sometimes the patient is drinking some of juice and this is causing hyperglycemia. So this is mistaken. So I may change the dose depending on this blood sugar, and this is not real, okay? And here, if we are admitting the new onset diabetic overdose adjustment, as we said, IV cannula for every patient unless you have a glucagon, blood sugar every 2 hours, basal insulin on admission, please. Once the patient admitted, especially if he's new onset, he should receive his basal insulin as soon as possible. Tresiba, Toujeo, Lantus, whatever. Okay, because he didn't receive insulin before. This is the first insulin he will receive. Bolus insulin, Pedia, Novorapid, or Actirapid, whatever, according to the order of the doctor. All patients on sub-Q insulin, Novorapid or Pedia, will take it before meal, just before meals, or within the meal, except if the patient less than 5 years, he will take it after the meal. Okay, because we cannot detect how many carbs that he will eat. Clear? This point is very important because it caused some problems last week because we have 2 admissions. One is 4 years and one is 7 years. Okay, clear? Act rapid. We don't have too much patient. We don't have too much patient on Act Rapid, but the only patients that we have, please, this patient admitting now, Sultan, he is on Act Rapid. He is taking it 30 minutes before meal. TID only, breakfast, lunch, and dinner. We are not giving Act Rapid without food overnight, okay? No correction overnight with Act Rapid because it's not rapid acting. It's short acting, like acting more than 6 hours, so we cannot give insulin. This is what happened before. The nurse gave a correction with Act Rapid like 2 or 3 hours after the meal, and this caused severe hypoglycemia to the patient. Correction overnight. Correction overnight with Novorapid only every 4 hours if the blood sugar is high and the patient is sleeping. You can give correction according to the equation you have. Please, for the new onset patient, we need to let the mother to give the insulin herself from the first day, unless if she is like still not relaxing or she is in shock. Okay, we can wait until the 2nd day. But for the new onset diabetic, we want the mother to give insulin herself, but the nurse should see her. Okay? Any questions?